a clinical perspective. I also invite the chairpersons, Dr. MP Singh, Dr. Harshita Tyagi, and Dr. Bharat Bhushan, please.
Good evening, everyone. Thanks, organizing committee, Dr. Paras, Dr. Mota, Dr. Vijay, Rajiv Bansal, and everyone for this opportunity. And what what has been assigned to me is to just do a context setting about metabolic syndrome, diabetes, and clinical perspective. So entire session will be like this. I'll be talking about diversity, just doing the context setting. Approaches in management, lifestyle intervention, diet will be done by Dr. Cheryl. Then Professor Madhu will do the treatment part, drugs, present and futures, and toward the end we will have panel discussion which will be based on the cases which they are going to take up. So let me introduce what is diabetes. It's a coexistence of both diabetes and obesity, term which was coined as early as 1973. Both these diseases or comorbidities are linked together with a common pathophysiological mechanism which revolves around insulin resistance and hyperinsulinemia, and these are very closely associated because diabetes risk increases by almost 4.5% for every 1 kg increase in weight. So it is something that we are passing through a dual epidemic of diabetes and obesity together because both have very detrimental effects on the health. And unfortunately, at least in India, almost 85% of all type 2 diabetes patients, they are either obese or they are overweight. So it's not surprising if we say that to 2025, maybe more than 300 million of people will have type 2 diabetes associated with diabetes. And as I said, it is a common comorbidity. So diabetes or diabetes and obesity together, they are partners in crime because together they increase the all-cause mortality by almost 7 times. But what is more important to us as Indian is that we belong to a thin-fat Indian phenotype where we have a very lower or very lean body mass with very high subcutaneous and more so a visceral fat. So maybe at a BMI of 23 to 25, which for us is already an overweight, that may be normal for a Caucasian patient, and anything more than 25 for us is obesity. So we tend to not only develop diabetes and metabolic syndrome at a much lower BMI as compared to the Caucasian patient. Let's understand the pathophysiology of diabetes. So wherever there is a positive energy balance, and overconsumption of calories and underutilization of calories, to put it very simple, it is going to be stored as energy, as fat, initially as subcutaneous fat, and then there is going to be a spill to visceral fat, which then stimulate all the pathways of systemic effects like inflammatory pathways, lipid overflow, and of course changes into the adipokines. So whenever there is a positive energy balance, there is initially going to be a saturation of adipose tissue, and subsequently there is going to be a spill which will then lead on to visceral fat and a lipid overflow leading on to visceral obesity, increased liver fat, epicardial and pericardial and myocardial fat also goes up. There is going to be deposition of fat into the muscles, into the renal sinus area also, and there is also unfortunately going to be a increased pancreatic fat which then leads on to growing beta cell dysfunction. So one end liver you have insulin resistance, on other end you have growing beta cell dysfunction leading to a stage of early onset of type 2 diabetes, and together diabetes does huge amount of harm on almost every organ you can count. Central nervous system, there is an impaired energy homeostasis. Liver, it induces by deposition of fat, severe insulin resistance in pancreas. Again, there is moment there is a deposition of fat in pancreas, there is going to be a beta cell dysfunction. Leptin resistance goes up and adiponectin levels come down, and even there are changes in gut microbiota from bacteroids to firmicutes population, which goes up, further inducing insulin resistance and into the muscles. Moment there is a deposition of fat into the muscle, that induces severe insulin resistance, and there is non-utilization of glucose into adipose tissue and muscles also. So overweight and obesity will not only lead on to higher risk of cancers, albuminuria, renal diseases, depression, retinopathy, obstructive sleep apnea is very, very common, and so overall morbidity and mortality is going to go up, and all the inflammatory adipokines are going to be on the higher side. With increase in white adipose tissue, FFAs, TNF-alpha, interleukins are going to be on the higher side. There is going to be an increased production of free fatty acid, with lipolysis adding to a typical dyslipidemia, what is seen in diabetics, or increase in insulin resistance with deposition of fat into adipose tissue as well as into muscle. Normally we say that once insulin resistance sets in, it almost stays constant. But if you see the study by Fanani, he said that as early as 2011, that in spite of the fact that insulin resistance starts much earlier, but still some amount of insulin sensitivity keeps going down as we move from NGT to type 2 diabetes. And obviously onset of type 2 diabetes happens because of growing beta cell dysfunction. We always thought that it was a disease of higher economical status. Well, even this study has proven, which is 2016 publication from British Journal of Medical and Health Research, that hypertension, diabetes and obesity together happen as we grow from poorer to middle, richer and richest population. Obviously clustering of risk factor improves, but we have seen in-depth data that now even that gap is also fading in rural as well as in urban population. So any amount of weight burden is not only going to lead to so many complications, so ultimately leading on to a financial burden, adding something like fuel to the fire, because moment you are overweight, the cost of overall morbidity is going to be much higher. So if you have a classical obesity more than 35 or 40, you will require almost 50% extra cost to manage those complications. And we know moment you have metabolic syndrome, insulin resistance as a precursor, in the setting of obesity, you are already at a stage of pre-diabetes or IGT, which then develops into type 2 diabetes, and it must be viewed as a diabetes continuum with gradual fall in beta cell function, which sets in the stage for development of type 2 diabetes. So there is always an added risk for development of type 2 diabetes moment you have obesity or impaired glucose resistance. So if you are only abused, risk may be only 5 times. If you have already impaired glucose response or IGT, risk of conversion to type 2 diabetes is almost 7 times. But moment you have obesity and impaired glucose response, obviously the risk for development of diabetes goes very, very high. So obesity related diabetes is a very, very relative risk. With every 1 unit increase in BMI, there is going to be a higher probability of getting converted to type 2 diabetes by almost 2%. And again, it is dependent on the BMI. Higher is the BMI, greater is going to be the risk for development of type 2 diabetes. And 90% of people with type 2 are, I told you, 87 precisely are overweight or obesity. That is why these days we emphasize in all guidelines, whether it was ADA, ACE or current ASD guidelines, and in our own RSSD ASI guideline, we talk about huge emphasis has been laid on weight reduction so as to cut down on all morbidities and mortalities, because weight reduction will not only improve insulin sensitivity, it will also preserve beta cell for some time. It will also have benefits in terms of glycemic reduction. If you can get down your weight by 5%, for every kg of weight loss, you might have an HbA1c reduction of 0.1%. And it is very, very important while prescribing an anti-diabetic drug today that we must have a balance, not only in terms of getting a good glycemic control, just finishing last slide, not only in terms of getting good glycemic control, but also changing the overall metabolic profile, because 5% weight reduction will reduce hyperglycemia, hypertension. 5 to 10% may almost prevent onset of type 2 diabetes in NAFLD or MAFLD, we just learned from Professor Serene, and 10 to 15% or more than 15% will do wonders in terms of not only a type 2 diabetes remission. So I'll not touch upon this part, what will be taken by her, that we have enough evidence that through all these lifestyle modification and structured education program along with exercise, we can cut down on progression of type 2 diabetes from IGT2 or maybe from IFG. Thank you very much. I'll stop short here and we'll come back with cases towards the end. Thank you very much.